Welcome again, my colleagues. This is our first ultrasound session. Candidate 1, 50-year-old female patient with lower abdominal pain. Go on.
Here I have here with me ultrasound images of the female pelvis. Mm, the uterus appears bulky with um, hypo hypo heterogeneous appearance of a hyperechoic structure within. Um, mm,
Yes, what else?
mm, it appears well defined with well defined borders and smooth borders. Um, no,
Okay, what is this? Concentrate here, please. What is this?
okay, this is ultrasound of the right ovary with increased Doppler signal at the periphery. Mm,
What happened here, doctor? What is this?
it appears cystic over here.
Okay, this is cystic. What is inside the cyst?
Mm, uh, it appears to be like a soft tissue lesion, I think.
What?
Is it, oh, sorry, doctor, is it like a soft tissue
Okay.
lesion?
What will you do next?
Mm, I think I can proceed with CT.
No. Look here, what happened? What
Um,
is this box?
Doppler,
Yes, what
color
happened
Doppler.
here?
There's increased signal at its periphery, at the
Referee only? What is this, doctor? What is this? This is not only periphery.
vessels. There are multiple vessels within as well, within the lesion as well. Um,
So what's your diagnosis?
um, Also able to see some cystic lesion. Um, and
Mhm.
yeah, right.
This is
Uh,
cystic or
I'll go.
cystic solid.
It appears cystic.
So
Um,
which you يعني is suspect malignant, aggressive or benign?
mm, um, I think I would say due to this increased Doppler signal, I would worry of malignant.
Okay, give me 2 to 3 differential diagnosis
Uh,
of malignant
so
ovarian tumors.
the one oh um, sorry, doctor means like ovarian now we suspect ovarian cancer.
Yeah, yeah.
Um,
Yeah, what is the type of ovarian cancer? Do you know? طب what is the name of general name of ovarian cancer? Cystic and solid like this.
cystic solid.
Mm. And the patient is not elder, just adult. يعني 50 in UK is not elder. Really. Because it's
Uh,
the elder there over 70, 80. One friend
Adeno.
of mine told me at morning, some patients are more than 100 years.
Oh,
Yeah. So this is
is it the
cystadenum.
cyst adenocarcinoma?
Okay, we have how many types? We have 2 types. What is the 2 types? Serous and
Mucinous.
mucinous. Okay. So your suspicion about this is cystadenocarcinoma. Why? Due to originally cystic, but with huge mass and
Mm-hmm.
See the vascularity, my colleague. Somebody may told me, doctor, it may be dermoid cyst. You are correct. It may be because it is hyperechoic and it is independent. But look, what is this? Internal vascularity. So not
Increase in.
dermoid cyst. Doctor, if
Okay.
we there are a classification system in the ovary called ORAD, like thyroid,
Okay.
like thyroid. If you wanted to give a degree, a score, ORAD score here, 1 from 5, which one will you give for this lesion? Two,
Mm.
3, 4, 5 for malignant lesions.
Sorry, doctor. I'm also not so familiar, but I believe it'll be higher score because it's has features of malignancy.
Yes, so we will give it 4 or 5 ORAD score.
Mm.
Mm.
Maybe 5.
5, okay, thank you. Like thyroid, like pyrate, the same.
Oh,
The
okay.
most probable malignant lesion should give 5. Thank you, doctor,
Okay.
so much.
Thank you.
It was a case of cystic solid malignant looking. They remove everything, by the way, and they go to biopsy. Sorry, they go to pathology. And here what happened? This is a polyp. Okay, why? There are rim of fluid here. Okay, rim of fluid. And we need, I think, yes, see, where is vascular pedicle? Here and here. At
Okay.
least this fluid is indicative of polyp, endometrial polyp. Thank you so much. Uh,
Mhm.
next candidate.
Assalamu alaikum, sir.
Salam. Doctor, this is 75-year-old male patient with high BSA.
Sir, can I scroll now?
I scrolling
Can
for
I ask now?
yeah, scrolling. Go on.
Okay. Okay. I am provided with multiple ultrasound images of the kidney and the lower pelvis. In the
Yeah.
kidneys, I can appreciate in left kidney a well circumscribed large cyst is noted in the mid pole protruding out of the renal cortex containing
Mm-hmm.
clear fluid. Uh, and no further solid mass is appreciable on this image. And no solid nodularity or calcification within the wall of the cyst. And this is causing compression over the mid-lower pole calyces, but no associated hydronephrosis is noted. I would like to see the rest of the images. Uh, yes, this is urinary bladder. No, this is, and again, the left kidney view in which I can also appreciate a large cystic lesion with the wall thickness having size of 9 into 6 centimeter with mostly clear fluid.
Mm-hmm.
No subtle, no septations or wall nodularity or wall calcification is noted in this cyst. So,
What's your diagnosis?
so till now, these cysts are benign. One at mid pole of the kidney, left kidney, and this seems to be at the lower pole most probably.
Yes. What's your diagnosis, doctor?
So these are benign cysts. Sir,
Benign.
these are large cysts, so I will keep them in the category. Yes, benign renal cysts. I will keep them in the category of Bosniak type 2A because these are large, and if the patient age is advanced, then I will keep them on follow-up after 12 months to
Okay.
check for intervention in size and appearance.
Okay, but it is type 2 because this very fine septation, by the way. Okay.
Yes, yes,
Thank you,
yes,
doctor, so much. I will show you here. So, my colleague, see, no any obvious enhancement. Even the septation that were seen by the ultrasound, not well seen here at all. Okay.
yes, sir.
My colleague Wozniak classification is very critical. I was in one very big interview, very big. they ask me one question, the most important one about Bosniak classification. I will see. I know most of you have has read this before many times and has some confusion. I will give you very simple way, at least to catch few of it. See, my colleague, type 1 is the complete benign, nothing. Wall thickness less than 2 mm and nothing else. And don't confuse your mind with it. Nothing. So type 1, 2 mm and nothing. Two words. Type 4, malignant with all criteria of malignant, either nodule, mass, solid mass with cystic necrosis, all. So type 4 is the malignant one with all criteria of malignancy. So very easy now. Type 1 is the pure malignant, pure benign. We will keep towards 2 mm and nothing. Type 4 is the malignant with all forms of malignancy. Any form that you know in your mind, both of malignancy, both in type 4. So the confusion always between 2 and the 3. 3, to diagnose 3, you should has enhancing thick wall more than 4 mm. And the 3 is towards the malignancy, more towards the malignancy. Okay? So 3, 4 mm. 3, keep it in your mind. 3 type 3 need 4 mm and enhancing wall, or the wall is enhancing and irregular. So type 3 all about the wall, all about the wall. Okay, my colleague, other than these 3 types, both in type 2. Don't confuse your mind, really. So again and again, type 1 two words, type 4 all signs of malignancy, type 3 about all about the enhancing thick wall, either regular and 4 mm or irregular enhancement. Whatever you see in the cyst from septation, from calcification, from turbidity, both in type 2. Even don't confuse yourself by type 2F like that. No problem. In the exam situation, really everything go distracted in your brain. So keeping the confusing information by very simple and clear buzzword will never confuse you. Okay, my colleague, this is clear? I think clear. Next candidate.
السلام عليكم.
Alaikum Assalam. Doctor, this is 35-year-old male patient with lower cheek swelling.
Okay, I have been presented with multiple ultrasound images of the left cheek for an adult patient with lower cheek swelling. I can see that there is swelling of the subcutaneous soft tissue, and in the inferior margin with the pain, I can see that there is which looks like a hyperechoic structure and surrounded by hypoechoic. Sorry, I can see that there is oval shape lesion is noted with a measurement written in the downward. This mass lesion containing high hyperechoic structure, but I cannot see any acoustic shadow, so this is not likely to present stone. I can see that there is soft tissue swelling. In the color Doppler, I did see that there is color uptake, so this is make it a vascular structure. I will compare the left side with the right side to see if there is any differentiation.
Yes.
This is the left side.
My colleague, please mute yourselves. Hello? Hello?
Yes, I'm with you.
Yeah. Yes, doctor. This is a
Yeah. So
slide.
I want to
Mm.
yeah. So I want to compare the left side with the right side if available.
No need, doctor. By the way, this is not subcutaneous. See the bone? See the bone? So
Ah,
this in the deep
ah,
tissue. Okay, what happened?
ah.
Doctor, you find this one, and this is
Yes.
solid or soft tissue, and there are vascularity. What's your
Yes.
diagnosis?
First of all, I am thinking about aggressive lesions,
What
such
else?
as
What else?
um, it could be due to complicated lymph node involvement, such as lymph node
And what,
necrosis or
doctor? One second. What about this?
yeah.
What is this?
This is could be stone
Or,
because it's appear hyperechoic.
or
Um, uh,
soft tissue vascular lesion with this one.
it could do with phlebolith, which
Yes,
could represent soft tissue hemangioma.
yes, vascular malformation, vascular tumor, anything,
Vascular malformation.
but you are in the vascular pathway. Okay?
Yes, yes.
Thank you, doctor, so much. This is not subcutaneous,
Thank
by
you.
the way. Okay? See the bone here, my colleague? This is in the deep
Yes,
tissue. Okay, containing
yes.
flocci or flipulus and vascularity. See,
First, I
must,
suspected that it is the phlebolith, but why there is no acoustic shadow?
see, I don't know, yani, maybe atypical.
Okay.
But at least you see, do you remember my advices before? Guess, expect. Don't wait for the typical cases. See, my colleague, I have been presented 5 years ago in my MD with one. I think this is the most difficult case I has been presented in any exam at all. It was an infiltrative, very malignant skull-based lesion, infiltrate everything, orbit, cavernous sign, everything. And finally, thanks God, I saw only one single fliply. I told the examiner, this is hemangioma. Very atypical case. Okay? So don't expect a typical finding. Like our doctor said, fliply. Doctor, it has some shadowing, by the way. See? It has some shadowing.
Yes, yes, yes. I see it now.
Okay? What we should do, my colleagues? We should guess. It's very important. I told you many times before, when you see the case, have a look. Tell yourself, I should run in the pathway, in the pathway of like 1 to 3. It may be vascular. I will run in the pathway of vascular mass, vascular malformation, the most important vascular abnormality. Thank you, doctor, so much. It was by
Thank
the
you.
way, lymphatic malformation. Okay, doctor, I have question.
Yes.
What is the difference between hemangioma and malformation?
Okay. I don't know exact answer, but I will try to emphasize. I think the hemangioma is more
One
like
word.
a soft tissue mass lesion
One
with
word.
vascular.
One
Yeah,
word.
one word.
One word.
I think in the vascular malformation there is abnormal communication between artery and vein, which is not seen within the
And
typical hemangioma.
hemangioma? Hemangioma?
Hemangioma, I think there is no fistula communication or
No. What else?
neither
What else?
between the artery and venous.
What else?
I think both will show phlebolith or calcification,
No, no, no.
but
Malformation is malformation. Hemangioma is a tumor. Again,
tumor, yes.
hemangioma is a whatever the type. Hemangioma is a tumor that have benign, locally aggressive, and malignant, like angiosarcoma. Okay, like
Okay.
benign, like the hemangioma that is a classic hemangioma. Hemangioma consisted of true tumoral cell. But any malformation, whatever the type, it is normal tissue in abnormal location. Very big difference. Okay, my colleagues, thank you so much.
Thank you.
Welcome. Next candidate.
السلام عليكم دكتور.
Salam. 16-year-old female patient with history of recurrent UTI. No need, no need. Very simple.
Okay.
Static images.
Okay.
1,
Okay.
3, 4.
Okay. These are ultrasound images of kidney. Not sure which side.
No problem.
I'm sorry. Can you repeat the clinical again? Sorry.
Recurrent
The
UTI.
clinical finding.
Recurrent
Okay.
UTI.
How old is the patient, doctor? Young
Adult patient. Sorry,
adult
16,
patient.
16, 16-year-old.
16 years. Okay. So in this image, this is the kidney shows normal Doppler vascularity. It has normal parenchymal attenuation and
Doctor, what is
thickness.
this? What is this?
This is, I think this is transplanted kidney in the
Not
psoas muscle.
transplanted. No, not transplanted. What is this?
Pelvic kidney, maybe pelvic kidney.
Okay, but you didn't have any clue for being a pelvic kidney or not.
Because there is, it's overlying a muscle.
Yes, what is the name of this
Can I
muscle?
check the other images?
One by one.
Okay.
What is the name of this
Here,
muscle?
yeah,
Psoas.
it should be psoas, yeah.
Okay, and this? Where is anterior from?
This is the vertebral column.
Yes, so
This
this
is the
anterior.
skin, subcutaneous tissue, it's superficial. Yeah, and this is the muscle, and then the spine. Yeah.
What about the orientation of the pelvic LCL
The
system?
hilum is, hilum is rotated anteriorly.
Okay, look here. What is this? And what is this? Do you think?
It can be,
Yes.
yeah, it can be fused together.
Yes. What
Um,
diagnosis?
I'm not sure where is this, where is the location? Is it,
No problem.
it could be a horseshoe kidney, or
Okay.
if there is no right and left, so it will be if crossed, fused, it will not be overlying psoas like this. I'm
No
not sure.
problem. You are correct. Cross diffused
Yeah,
ectopia.
ectopia. Yeah, renal
Okay.
ectopia, but the side is not mentioned. Yeah.
See here. See here. See the CT. What happened? See?
Okay. Yeah.
I think
Okay.
this is no. This
So
is cross diffused ectopia. I was about to tell it may
yeah.
be pancake kidney, but there are some differentiation.
Okay.
See
Okay.
here, very clear here.
Okay.
Okay, why I bring this
Okay.
case? We must guess, my colleague. The examiner
There is no label, doctor. This way.
okay, give
I don't
you
know where is the side. The
a case
side.
like this.
Yeah.
And
Here in this one, it looks two fused. There's one complete and another one partially imaged, and they are fused together in this
okay.
image.
The examiner give you a case like this, and it looks like only one
Mm-hmm.
kidney. And here there are mal rotation. The Doppler confirmed
Yeah.
it. So give him at least two differential. Doctor, it may be, I will examine the patient to the contralateral side. If there are no kidney, I would be concerned or worried about cross-diffuse ectopia. Okay, or it may be duplex kidney. This is upper moiety, this is lower moiety. I will examine the midline. If this image, but this is not in the midline, by the way, because this is south. Anyway,
It
doctor,
could be, it couldn't be in the midline, because of
okay, like this.
source.
So this case is for expectation, for guessing. By the way, the exam should be more clear than this, to be fair. To be fair. But I want from all of you to use all skills, all weapon, okay? To get the highest marks. Guessing really is very important in the exam. Thank you, doctor, so much. It was gross diffuse ectopia.
Thank you. Thank you very much.
Welcome. Next candidate.
Assalamu
عليكم السلام. Doctor, this patient, 45-year-old patient with sustained right shoulder pain.
Okay. This is a right shoulder X-ray AP view.
1 second. Doctor.
Um,
1 second. Yes.
yes. There is history of right shoulder pain and previous trauma.
Yes.
So I am looking for any fractures. No obvious fracture could be seen in the clavicle or scapula or in the visualized proximal humerus.
Yes.
There is no evidence of rib fractures and no evidence of pneumothorax in the visualized lung field. There appears to be some soft tissue thickening.
No. What else?
Okay. There is a mild patchy area of sclerosis at the greater tuberosity of humerus, which could be due to degenerative changes.
Okay. See, this patient, the X-ray
Yes.
is unremarkable. Okay.
Okay.
But he has
Okay.
a trauma, and after the trauma, he developed inability to abduct his shoulder. What will you do next?
MRI.
Before MRI,
Ultrasound.
ultrasound shoulder. By the way, my
Yes.
colleague, now it is يعني since 5 years ago, the first line of investigation in trauma, in MSK trauma, especially muscle, not MRI, is
Yes.
ultrasound.
Okay.
Why? Because in the first few days, the marked edema in the joint, in the muscle, really obscure and يعني deteriorate everything. You may make the diagnosis a very aggressive diagnosis, and after 3 days, everything is disappearing. What? Okay. So after
Yeah.
any injury, MSK injury, do MRI. Sorry, do ultrasound. Doctor,
Yeah.
go on.
Um, okay. There is evidence of low echogenicity
Uh-huh.
noted at the insertion of supraspinatus muscle
Yes.
with the that is likely suggestive of injury.
Yes. What your doctor requests the control?
Okay. Okay, I'm requesting.
Show me where is the injury. Show me.
Okay. 1 second. I try to move the mouse. Okay. This region.
Excellent. You are brilliant. Despite here, he measures something here, but really, this hypoechoic area, this is the defect or the gap.
Yes.
Okay, my colleague, very important. Leave the mouse. Thank you, doctor.
Okay.
If I am examiner, I will ask you this question only. If you know,
Okay.
I will give you a good mark. If you didn't know, I will fail you. Didn't pass you at all.
Oh,
Why? Because supraspinatus ultrasound is none or all. Either you find a gap or not. Nothing else. Gap,
right.
this gap of fluid. See, my colleagues, I wanted to show you the normal because this is very important, and most of us didn't do shoulder ultrasound. Very important. Very important. It may be exam case, sure. Why? Because it became you can't imagine the frequency of shoulder ultrasound. Really. Look. I will show you one. You should see there normal. This location. 1 second. You should be sure that you see the normal appearance of the tendon is fibrillar fibers and the fibers and the fibers. I didn't see at least here. Sorry, my colleagues. Shoulder at 7. Okay. See this one, my colleagues? See?
Hello, everyone. This is Dr. Sam.
Very important, my colleague. What happened here? Look here, please. You should see this hyperechogenesis. By the way, there are tendinosis, okay? This is not there are some tendinosis here. In my opinion. But you should see all the tendon like this hyperechoic, like this, no any hypoechogenicity, and you should see fibrillar pattern, fiber parallel to each other. Very characteristic, my colleagues. See here normal hyperechoic and little bit fibrillar. Here there are hypoechogenicity, tear. Whatever partial, complete, but at least you should train your eyes. This is the tear. Okay, my colleagues? Very important. Hello?
Yes, yes.
Sorry, because this is very important.
Yes,
What do you think? This is complete tear or partial?
this is complete tear.
Okay, what will you do next?
I would next refer the patient to orthopedic and advise further MRI
Okay,
to see other injuries. And
during,
I would also like to see other muscles on ultrasound
okay.
of the as other muscles of the rotator cuff.
What is the most common cause of this tear? What is the most common etiology?
Most common is trauma,
No. What else?
degenerative changes.
Excellent. Of which joint?
Degenerative changes at the acromioclavicular joint.
Brilliant. But here, look, my
Yes.
colleague, this is the AC joint. This is the acromion. This is the clavicle. Okay? This is normal, by the way. So, this patient of trauma and the patient is not elder. Okay? But most of the
Okay.
patient of cerebrospinatus tear are due to degenerative changes of AC joint. Thank you, doctor, so much. Doctor, do
Thank
you
you.
know
Yes.
most critical or most dangerous type of acromion that cause tear?
Type 2?
No.
Sorry.
Type 2 is a little bit borderline, but not critical. What else?
I'm not sure about it. I think this question also came in 2A.
Okay.
I've forgotten.
Type 3 and 4. Why? Type 3 and 4
Uh,
because one of them has a hook and one of them has a convex border. So this hook or convexity um, exert a fraction means tearing power on the supraspinatus. So type 3 and 4. Okay. Also low-lying acromion or os acromial. What is os acromial, my friends? When this acromion is not completely fused with its epiphysis. it is another cause of shoulder pain and it is a predisposing factor of supraspinatus tear. Low-lying sloping acromion, acromial type 2 and 3, and osteoarthritis here. Okay, my colleagues, thank you so much.
Okay.
Next candidate.
Talim, sir. Yes, sir. Next.
Salam. Doctor, this 30-year-old female patient with thyroid abnormality, what do you think?
Okay, sir. Sir, these are the static images. I can appreciate that the thyroid gland shows a heterogeneous nodule identified within the left lobe,
Yes,
which is showing some spectra of calcification as well as some cystic areas.
yes,
The rest of the thyroid shows homogeneous texture, but there is a single nodule with
yes.
calcium to also check the vascularity of this nodule. So vascularity, Doppler. Okay, sir. So let's sir, it shows some vascularity or as well. It's a fairly defined nodule within the left lobe. Okay, sir. So,
Tell me, what happened?
so this nodule is noted. So, sir, initially I was thinking of a small polite cyst, but it is more solid and shows some vascularity as well.
So, what's your differential?
So this may be in this first there's classification module. So this may require FNUs. I think type 3 lesion is this.
Yes, huh? Give me Dr. Tirade.
Yes, yes, sir. Sir, I think it's type 3 to 4 because it shows vascularity in mild height. It's heterogeneous, so this requires biopsy. I think it's 4.
Again,
Direct 4.
doctor, please look below. Please look again. Look again.
Okay.
Again. What happened for this mass? Mass, solid or cystic?
Solid, sir.
Okay. Containing calcification
Yes, sir.
or not?
Yes, sir. It contains calcification and it
And
shows irregular markings.
okay, okay,
Yes, sir.
okay. What about this
Okay, sir.
and this, which is
Okay. Sir, it is, I think, wider than taller and it shows
yes.
ill-defined
So
margins. Yes, sir. So it's a 4 or 5. It's a neoplastic region.
so what will you do next?
Sir, this require histopathology. It's require
Are you sure?
biopsy.
Are you sure?
Sir, we go for scintigraphy as well, and if it's a cold nodule, then do. But this shows heterogeneous. But it's required biopsy. Yes.
Are you sure?
Sure.
The patient
Yes.
is still under your hand in ultrasound. What will you do?
Okay. Sir, I will also check the lymph nodes of this patient. This because maybe
Excellent.
calcified lymph node will be
Excellent.
in the rest of
Sure.
the neck. So it's also confirm my appointment. Yes.
Sure. Excellent.
So, sir, I will check lymph nodes.
So we should check lymph node. What is the criteria of malignant lymph nodes?
Yes.
Tell me.
So usually they shows a thickened cortex more than 3 millimeter, and they may also show the internal vascularity. Granulomatous also show, but in thyroid papillary carcinoma, calcified node, we find calcified lymph nodes.
Okay. So final diagnosis. This is thyroid
This
4 or 5.
neoplasm. So I didn't find lymph nodes, so I will go by 5.
Yes. So what will you do? What would you do next?
Sir, next I will find this requires CT scan as well, And also, first I want to check the lymph nodes. If lymph nodes are there or not, then CT scan, then histopathology.
What about FNA?
Sir, I know, sir, because solid lesion, I think biopsy would be better. It depend on the size of the lesion. If it's a solid, more better to have a biopsy.
Okay, but we should take a biopsy, doctor. We should take a biopsy. Okay?
Yes, sir. Yes, sir.
Okay. So see my colleague, what happened here? Taller than wider and calcification. Ill-defined heterogeneous mainly hypoechoic, taller than wider. This nodule at least give 5, by rate 5, at least. This is sure malignant. Or at least يعني until proof otherwise. Next is lymph node. What is the malignant criteria? Number one, loss of normal kidney or oblong shape. So it become globular with absence of the fatty hilum and thick cortex. Lymph nodes may contain calcification. Doctor, what is
Yes,
the common type of thyroid cancer that
sir,
could
follicular, sir. Yes, sir. Follicular or type are more common. Papillary carcinoma and follicular carcinoma.
okay, which one of them is more associated with calcification?
The papillary carcinoma are associated with
No,
calcified lymph nodes.
no. See.
Medullary carcinoma.
Yeah, yeah. Medullary carcinoma.
Yes, yes, yes.
Okay, but
Yes,
the most
yes, sir.
common, see my colleague, this point is very important. The most common thyroid cancer that in its nature cause calcification in the lymph nodes or associated with calcification is the medullary. But because of the papillary is very common, most of the calcification cases related to the papillary. Okay? Despite the papillary itself is not the commonest cause of calcification. Is it clear? Is it clear?
Yes.
Mm. The most يعني the medullary one is the highly يعني one associated with calcification. But it is rare. Its percentage of thyroid cancers very low. The papillary one, due to its high prevalence, it become the more common to be the cause of calcified lymph node. Thank you so much. Next candidate.
Hello.
Welcome. 3 weeks male patient with vomiting.
Okay, these are grayscale ultrasound images of upper abdomen, pylorus, of a 3-month-old baby having history of vomiting. I can see that there is marked thickening of the gastric pyloric region, forming a cervix sign, and there is hypertrophy of the central gastric mucosa. And also there is it is forming cervix sign. It measures, I think, more than 16 mm, and there is a dilatation of the proximal stomach, showing food residues. So these are findings are suggestive of hypertrophic pyloric stenosis. However, I would like to see this on the transverse images to further see the target sign. Yeah, also, this is the transverse image further confirming and supporting the diagnosis of hypertrophic pyloric stenosis. The wall thickness is more than 3 mm. And also the mucosa is appearing as echogenic and causing luminal obliteration. So findings are suggestive of hypertrophic pyloric stenosis. So I will inform the findings to the referring physician and will suggest referral to the gastro and pediatric gastroenterologist for further management pylorotomy in this case. Thank you.
Thank you, doctor, so much. Doctor, what is the most common complication or presentation that this patient may be presented or almost presented with?
Sir, mostly these present with projectile vomiting.
No,
And
doctor, you didn't take
sir,
repeat my
sorry.
question.
There is malabsorption of the nutrients. So
No, no,
uh,
no. Say again. I will I will repeat the question. What is the most common complication? Not see, not symptoms. Symptom is projectile vomiting. What will be a consequence of repeated projectile vomiting?
maceration or yeah, I said alkalosis and also there and
Yes,
also
correct.
malnutrition.
Correct. Disturbance in the pH, like alkalosis, malnutrition overall. But alkalosis is very important. If you forget in the exam and you don't know, we are not a clinician or internal medicine, doctor, the pH should have some significant disturbance, like alkalosis, because he vomit acid, and finally he should have alkalosis and malnutrition. Malnutrition. Okay. Thank you, doctor, so much.
Thank you, sir.
Anyone has any doubt about the measurement here? Because many of our friends ask us, the longitudinal, this one should be more than 16 mm. The transverse, should be more than 14 mm. If you measure each side alone of the muscle, should be more than 3 mm. Okay, my colleagues? Treatment here only pyloroplasty, sorry, surgical. Next candidate.
First, excuse me, I have a question. The most common complication is electrolyte disturbance and malabsorption.
Yes.
I have to say the alkalosis or electrolyte.
See, not malabsorption, because when this baby يعني has take his food, it is immediately vomited. Okay, absorption or not, most of the absorption occur in the small bowel, more than 90%. Okay. Hello.
Okay.
See electrolyte imbalance or disturbance, pH, uh, malnutrition. That is clear? Hello,
Yes, clear. Thank you.
La, you wanted to tell something. You wanted to say something. Tell me. You have some objection.
Yes, I want to ask about the type of electrolyte disturbance
I don't
that
know.
is associated with biliary stenosis. Okay.
I don't know really. But at least UK examiner, because their career, all over their career, they are a clinical radiologist, wanted to ensure that you know the consequences of the complication here. Do you know, my colleagues? Uh, I have before work in one surgery hospital. We have one patient comatose for 3 years. It was, by the way, يعني not very good hospital, but anyway, 3 days post-operative comatose patient. And finally, they ask one consultant to come. He asked for some electrolytes and pH and gave some treatment. 1 hour, the patient get conscious. I am telling this story to estimate the value of electrolyte and pH. Very critical. Okay, my colleague? Doctor, this is clear?
Yes, clear. Thank you.
Okay, thank you. Next candidate. Next candidate. Hello? Hello? Dr. Nagam? Which candidate, my colleagues? Hello?
Yes, 7 is around. Please proceed.
Assalamu alaikum, sir.
7.
Alaikum salam. Doctor, this is
Assalamu alaikum.
yes, alaikum salam.
Hello.
Yes. Doctor,
Yes.
this is a 60-year-old male patient with elbow pain, severe elbow pain.
Okay, sir. This is the grayscale ultrasound image taken through the elbow joint, in which I can appreciate there is a retraction of bicep tendons
Yes.
superiorly towards the shoulder joint, and it is occupied by fluid containing structure, and rest of the muscles appears normal. Overlying subcutaneous soft tissue and skin thickening is normal. So it's a complete tear of bicep tendon with the fluid in its canal. Next, I would advise MR to the patient for further confirmation of my findings.
Brilliant, doctor. Doctor, what is the cause of biceps tendon rupture?
Sir, I think marked extension of the joint.
Extension or flexion?
Sir, sorry, I clearly don't hear. No.
No, the elbow, the biceps extend or flex the elbow.
Sir, elbow flex, but I don't know the exact cause.
Yes, sudden severe in gym player, in athletics,
Okay.
sudden severe contraction of the biceps due to flexion, sudden severe flexion of the
Okay,
elbow, especially
okay, sir.
those athletics who use weights during a training. Okay, this is very, by the way,
Okay,
very
sir.
common, very common.
Okay, sir.
If any one of us go to gym, they know that there are a special movement or training for the bi and the tri. Okay.
Okay, sir.
Sudden
Okay.
severe. Thank you, doctor, so much.
Thank you, sir.
Next
Thank you.
candidate. But doctor, this patient was 60-year-old. Okay.
Okay, sir.
What is the predisposing factor in old age? Generally, I'm generally speaking, which too much predisposed to tendon rupture.
Sir, mark degenerative changes.
Okay, what else?
Sir, in the supraspinatus tendon, like Milwaukee shoulder hydroxyapatite deposition, but
But
it's a cause of supraspinatus tendon.
do you think diabetes may be a predisposing factor or help in more easier rupture?
Sir, hydroxyapatite crystal, yes, cause more easy rupture.
Yeah, I'm talking about diabetes. Patient with diabetes are more liable to tendon rupture. Are you agree with me or not?
Yes, yes,
Okay, especially see, this patient of 60, almost he didn't go gym. He
yes.
retired. Thank you, doctor, so much.
Thank you. Thank you.
Welcome, next candidate. Next candidate.
9. Please proceed. 9.
Okay. Assalamu alaikum, sir. Can you hear me?
Yes, sudden severe lower leg pain. What do you think?
Okay. This is the lateral X-ray projection of ankle, right ankle, in a patient who presented with sudden severe pain, in which I can appreciate that in the line of Achilles tendon, there is there is some density is seen in its middle part, just above the attachment. And if the patient has presented with sudden severe pain, and in the retrocalcaneal region in the Achilles tendon, there's hyper density. So I will correlate with ultrasound finding to rule out Achilles tendon tear. So this is the location of in the lower part of the Achilles tendon, just above, almost 1 to 2 centimeter above attachment. I can appreciate that there's a discontinuity and irregularity in the continuity of the Achilles tendon. And in my routine practice, I would like to measure its how much is the size of the defect, because this thing needs to be communicated to the orthopedic surgeon. Also, there is some hyperechogenicity in the adjacent retracted part, which is suggestive of hematoma. I will also scan the lowermost part to see any bony chip or any focal bony irregularity. So my findings is that it is acute Achilles tendon complete rupture with a defect and a lower pole hematoma.
Thank you, doctor, so much. Doctor, what do you think about the management?
Sir, the management is in complete tears. It is surgical.
Okay. Doctor, do you know that the most difficult tendon repair or over the body is Achilles tendon? The most
It is
difficult
Achilles tendon.
Achilles tendon.
Yes, because
Yes. Why?
it is associated with it is a dependent most part of the body, and
Yes,
there is
excellent.
always pooling of blood,
What else?
and moreover, patient is always walking.
Yes, what
So
else? Something related to the tendon itself.
uh, I don't know, but it has a history associated with some English actor or something. It has a history associated.
See, the
So
tendon,
it leads to
I
permanent
will tell you,
disability.
the tendon is itself is very thick. Do you know which is more easier to repair? To repair one sedan small car or to repair Land Cruiser? Which one is difficult?
To repair a small car.
Which one is more difficult? Small.
Land Cruiser is more difficult.
Yes, this is the Land Cruiser of our body. Very large, by the
Mm.
way. In Egypt, we have one very common doctor for repairing only Achilles. He didn't do anything other than repairing Achilles. To see how extended it is,
Mm.
very difficult operation. Second, it is it move all the body, by the way, because it transfer all the movement to the calcaneus. So it is most dependent, like you say. Okay. Third, do you know anyone know why this is very difficult? Third point, why? I will tell
Mhm.
you. Because the most common site of injury is the musculotendinous part. And by the way, it is يعني the most less vascular part. Okay, my colleague. By the way, this
Mm.
question is not common in the exam, but keep in consideration. We don't know. The most important in this case, this one, my colleague, really very easy to be missed. Very easy. But here, look here, just some irregularity and ill-defined, and piece, this piece of soft tissue looks like cut from here. At least, by the way, I think this is a tear itself. At least you have seen that the Achilles tendon soft tissue is not the normal one. If you told the examiner, I highly suspect tear, uh, and this is normal, he will not kill you. But
Mm.
if you missed it, really, really, he will give you zero in this case. Why? Emergency. Or not emergency, but a very critical, very important. Okay, and very easy to be missed. Thank you, doctor, so much. Next
Mm.
candidate.
Thank you, sir.
Sorry,
Assalamualaikum, sir.
colleagues, I'm trying to, يعني, my target of the session, especially as long as we are becoming near from the exam, to concentrate more and more in the technique. Okay, all of you know everything. Doctor, I think this is rest ultrasound.
Okay.
40-year-old female patient with wrist pain. Go on.
Okay, so I think this is the this is a tendon basically. I'm not sure which
Sure.
finger it is.
Okay,
Maybe
okay.
ulnar side. But it is showing some slight synovial thickening with surrounding edema and synovial effusion. The tendon also appears to be slightly enlarged and more
Look here,
echogenic.
doctor.
So,
Look here.
yes, sir.
This
Yes,
is
yes, yeah. This is
cursor or note. This is telling you he
yeah.
examined this most medial part. Most medial
Yeah. So
part.
this is likely flexor ulnaris tendon.
Okay, ulnaris, something ulnaris. Okay, what happened here?
So this is a case of tenosynovitis of the tendon of the fifth digit.
Excellent. Doctor, this is
And
synovitis or synovitis? What's the difference?
tenosynovitis, when involving the tendon, is also showing changes. So
So
I think
this
it is
is tenosynovitis or synovitis?
I think it's tenosynovitis.
Brilliant. Look here, my colleague. You should see, it is better to assess the muscle, the tendon, and longitudinal. By the way, my colleague, this is very good example for normal fibrillar pattern of the tendon.
Yeah.
Look, very good. Okay, my colleague. By the way, this is not the diseased one. This is normal tendon. Why? Look here at the cursor, at the sign, other than our tendon. But look here, this is our tendon. I think, see here, I think, look here, this is the diseased tendon. This is not the classic, typical parallel fibrillar pattern. Compare this one with this one. Train your eyes, please. Train. Thank you, doctor. This is
Thank you, sir.
tenosynovitis. Next candidate. Next candidate.
12, please proceed.
Sir, can you hear me?
Yes.
Hello.
5-week male patient presented with hematochezia and abdominal distension.
Okay, so I've been provided with ultrasound abdomen of a child. I can see that multiple hyperechoic foci are seen in the liver, which are extending up to the periphery of the liver. So given the extension up to the periphery, I have a concern of portal venous gas. Pneumobilia would be in the central area. So these hyperechoic areas likely represent portal venous gas. I would ask for X-ray of the abdomen to look for any pneumatosis in this patient. The gallbladder appears grossly normal.
Okay, what's your differential?
Some are differentials are portal venous gas and pneumobilia. Most likely, this is portal venous gas because the foci are extending up to the periphery. Most likely, this occurs secondary to any neck necrotizing enterocolitis, which then extends into the liver. The gas extends from the bowel wall into the liver.
Do
There
you
is also
think
mild
do you think
peri.
pneumobilia occur due to necrotizing enterocolitis?
No, it's portal venous gas. Pneumobilia is a differential in this case, but it occurs in the central area. This is extending up to the peripheral region.
What is the difference between portal venous gas in adult and in neonate?
The portal venous gas in neonate is not necessarily a very aggressive outcome. It can
Excellent.
occur normally. In adults, it occurs secondary to bowel ischemia, and it's a very grave sign in adults. In neonates, it can be a normal finding, but a patient it's not necessarily very sick in portal venous gas. So we have to look for any free air in the abdomen if
Thank you,
to
doctor.
give a very aggressive outcome. Yes,
Thank you
thank you,
so
sir.
much, my colleague. If anyone presented with X-ray for this patient, immediately he will pick up the necrotizing enterocolitis. But look here, the ultrasound, really, we are not familiar with it. Okay, my colleague. Thank you, doctor, so much. This is, by the way, pneumatosis intestinalis, mural air. mural air. Thank you so much.
Thank you, sir.
Next candidate. Hello, Dr. Nagam.
Hello.
Yes, candidate 13.
Okay. Yeah.
Doctor, this is 30-year-old female patient presented with swelling at the elbow. I think at the elbow. Yes.
Okay. So I've been presented with
Distal
severe.
arm swelling. What happened here?
So here I can see that there is a linear structure which is abruptly ending, and it is associated with the soft tissue swelling which is occupying
One
the
second.
distal end.
Look at this linear structure. What is this?
This seems to be a nerve,
What?
nerve or a tendon.
Tendon. Tendon
Yeah.
surrounded by large soft tissue mass. What do you think?
Yeah. So this could be due to a synovium.
Excellent. Synovial mass. Give me a
So
differential.
yeah.
Give me a
So
differential.
synovial sarcomas.
Okay. But look here. Do you think the sarcoma will be enlarged like this without infiltration here? What else?
No. So this could be synovial proliferation due to any arthritic involvement.
What else? What is the
Or
name? What is the name of synovial
tuberculous.
tumor? No, no. What is the name of
Sorry.
synovial tumor?
Um, synovial tumor. This could be due to PVNS.
What? Pigmented
PVNS.
Okay, okay. But this is tendon. You are right, by the
GCT
way.
of the tendon.
GCT.
GCT of the tendon.
Yes. So my colleagues, the GCT or giant cell tumor of the tendon is the same name of VVNS, pigmented villonodular synovitis. Look here. How to know to be sure? This is my colleague. This is the normal, the classic appearance of synovial thickening. This is relatively low signal. Relatively low signal is characteristic to the synovial. Okay? And
Okay.
and look here. This is, I think, gradient. Look, complete loss of signal here in compare of here. Okay, my colleague. This is synovial thickening. Here, complete blooming artifact or signal drop. Thank you so much. Next candidate.
Thank you.
Welcome.
Assalamualaikum, sir.
Wassalam. Doctor, this is 25-year-old female patient with long-standing thyroid problem. What do you think?
Okay, sir. I am presented with the ultrasound of the thyroid region taken with linear high frequency probe, in which I can appreciate that there are altered, yeah, the hypoechoic heterogeneous signals are noted involving the bilateral thyroid gland, and their size, however, is normal, and it appears to be reduced. I will measure them, and upon the color Doppler analysis, so can you please open the color Doppler? There is reduced to no blood flow noted upon them upon color Doppler analysis. I would like to correlate my findings with the history of the patient. I would advise thyroid hormone profile. And so,
Doctor,
keeping in view
doctor,
the imaging
Dr.
findings,
Omer,
yes, yes,
before
sir, yes.
any suggestion, give the examiner any differentials.
Sir, it is likely representing some autoimmune process which has resulted in
Which autoimmune?
defunctioning of
What is the name of
sir,
disease?
Hashimoto thyroiditis.
Okay, at least tell the examiner this is thyroiditis.
Okay, okay.
Whatever, Hashimoto, any say, but at least you you give a diagnosis. Okay, this is
Yes, sir.
Hashimoto. What will you do next?
Sir, I would correlate my findings with the thyroid hormone profile,
And
If I told you this is long-standing case, what you are worried about?
sir, I am worried about any other autoimmune disease, and also sir, there is no vascularity. So, sir, I'm
In general, doctor, in general, long-standing Hashimoto has many serious complications.
mm, sir, it can complicate into a malignancy like lymphoma and
Yes, lymphoma and
sir, carcinoma.
okay, brilliant. Thank you, Dr. Umair, my colleague.
Thank you.
My advice to all of you, Dr. Umair, see, the examiner want from your side two buzzwords here. Number one, after description and everything, this is thyroiditis. At least if you told
Sir, can
him
I ask something, sir? In thyroiditis, usually we
one second,
get a market.
one second, give me one my chance. At least
Okay.
I'm telling you at the worst plan, at least we should tell the thyroiditis, or it is better to tell him this is Hashimoto. Why? Why? Because he want to listen from you if you know the extent of complication here or not. Hashimoto, why I bring this case? I want one word, the complication of Hashimoto. One word only. Why?
Mm,
The complication is malignancy. Okay?
yes,
Ask me,
yes.
Dr. Umar.
Sir, I was asking that in thyroiditis, we usually we get increased blood flow. So,
Yes, yes. This
uh,
is maybe post-thyroiditis. Sorry, post-thyroiditis. Okay?
okay, okay,
Okay.
okay.
Post-thyroid, I'm falsely answer it. But يعني at least what I'm telling now about the technique, we are
Yes,
describing
sir.
very good, very excellent. But before
Yes, sir.
management, tell the examiner about your differential. This is very important. Okay?
Okay, sir. Okay, okay, sir.
Okay. This is the better to be said post-thyroiditis. This is the correct term. Thank you, Dr. Omer.
Yes, sir. Thank you, sir. Thank you so much.
Welcome. Next candidate.
Hello, sir. Good evening.
Good evening. I think this is the same case. This is the same case. Welcome, doctor. Doctor,
Should
this
I
is
start?
35-year-old female patient with pelvic pain. Go on.
I'm presented with CT, EVSG, ultrasound, and MRI sections of 35-year-old woman with pelvic pain. I can notice that there is a well-defined hypoechoic cystic lesion in
Yes.
pelvis
Yes.
with hyperechoic parts
Yes.
and low-level internal echoes. So I would
Doctor,
like to.
doctor, one
Yes,
second.
sir. Yes, sir.
Concentrate again. What is this?
This is the ovary.
This is a cystic lesion. Okay. What is this?
Yeah, cystic lesion in.
Yeah.
This is a solid part, most probably fat.
Okay. We don't know fat or not because you told me low level internal echoes. So you go in the incorrect pathway. What happened here? Fat or soft tissue?
This is soft tissue.
Why,
Uh,
doctor? Doctor,
there are
do you detect true vascularity inside it?
no.
So fat or or solid?
This is fat,
What's your diagnosis?
dermoid,
Dermoid. But low
dermoid
level
cyst.
internal echoes, this buzzword is
The,
about hemorrhage. This is
sir, I wanted to tell
yes, tell
the
me.
low level internal echoes in the cystic part. I wanted to tell there are hair or echogenic parts. What is seen in dermoid,
See,
and the solid part. I wanted to say it's
see,
fat.
this is the echogenic part and the solid part. Actually,
Yes.
here no obvious low level of internal echoes. But see, This
Okay,
this buzzword about the hemorrhage, low level internal echoes.
okay,
Okay.
okay. Hmm.
Yeah,
Okay, sir.
I want for you from your side to be clear because see, I will give you a history from one of my bad histories. Once I have one examination in Egypt and cavernoma. I told the
Okay,
examiner there are many names of cavernoma. I give him one of the non-common names. He didn't pass me.
okay,
See, this is the issue.
okay,
Common is common.
okay, sir.
Okay, look here.
Okay, sir.
Look,
Hmm.
look.
Yes, it is dermoid. Fat areas and calcification are there.
Yes.
Hmm.
Where is the hemorrhage here? Nothing.
No,
Thank you so much.
thank you, sir.
Next candidate. Doctor, do you know the difference between dermoid and the sebaceous cyst?
In sebaceous cyst, it is in superficial subcutaneous tissue,
No,
and
I'm talking about the pathology. There are good
pathology.
difference.
We get three elements, ectodermal elements in dermoid, uh, but in sebaceous cyst, we get calcification
No,
sometimes,
no, you are no,
thick.
no, no, no. Come back, come back. What about the ectodermal? Hmm. Think.
Ectodermal components we have in dermoid, like tooth, hair, and nail.
Okay, okay. See, my colleagues, the difference between sebaceous cyst and the dermoid, the numbers of layers. The dermoid at least has two type, at least or three, because normally we have ecto, meso, endodermal layers or
Yes,
origin of
yes.
tissues. In
Mm,
sebaceous only have one type, the outer, the ectodermal. And
okay.
sebaceous material is from the sebaceous glands. Okay?
Mm, okay,
Pathologically,
sir.
sebaceous cyst is one only one layer, almost ectodermal. But in dermoid, it must contain two or more, ecto and meso. Why? Why? Look here. How many types of tissue here? Calcification is not ectodermal at
Mm,
all. It may be, I didn't remember either endodermal or mesodermal. Okay?
okay,
And
okay.
it has some epithelium. So at least two type. But in sebaceous cyst, it contain only sebaceous material which is secreted from the sebaceous gland. The difference in numbers of layers, ecto, meso, endodermal. Thank you, doctor, so much. And by the way,
Okay,
in
okay,
some
sir.
cases of dermoid, we may see tongue, hair, thyroid like this. Thank
Okay,
you so
okay.
much.
Thank you, sir.
Dr. Nagam, did we finish our 15 candidate?
Yes, sir.
Come, Dr. Nagam, because I want you to finish. It is
Okay.
your case. 40-year-old female patient presented with weight loss and palpitation.
Okay, so I'm presented with ultrasound for a 50 years old patient with weight loss. This is the thyroid. I can see the thyroid shows gross enlargement with inhomogeneous appearance and increased vascularity. No discrete nodules. So my differential till this point is thyroiditis.
Excellent.
That could be Graves,
Why?
Graves or
Why not
autoimmune,
Hashimoto here?
because it's not that heterogeneous with no linear echogenic bands, and it's not shrunken.
See, but Hashimoto has يعني acute and chronic changes. Okay? I didn't mean
Okay.
chronic Hashimoto. Why this is not the acute stage of Hashimoto or the early stage of
Okay,
Hashimoto?
it's not heterogeneous.
It
The appearance is not characteristic of
little bit
Cushman's. Yes.
heterogeneous, but Hashimoto is more severely heterogeneous, even in acute state. Okay, doctor, what will you do next? What you are worried about of Graves patient?
Okay, Graves is a multi-system disorder. It can affect the orbits, can affect the digits. So I would make my complete study. I would like to check for the airways, as it's dorsally enlarged thyroid, maybe compressing the airways. I would like to correlate with the patient autoimmune profile.
What about the hand?
Yes, it
Thyroid
causes
acropathy,
acropathy.
very characteristic. Mm.
Yes.
In orbit, what is the underlying mediator, pathology mediator? What causes the orbitopsy?
The autoimmune process.
Excellent.
It
There
mainly
are
causes, yes, enlargement of the.
specific antibody. Do you know its name?
Not so much sure. Is it IG4?
No, no. This is
Okay, I'm not
another.
sure.
Huh? What else?
I couldn't recall.
Lattice, long-acting thyroid stimulating antibody. Anyway, this is not important, but just I'm trying to give you as much as possible a typical question. Lattice. Okay.
Okay.
See, this is thyroiditis. Thyroiditis me a part of IgG4. I'm agree with you. And the orbitopathy also may be a part of IgG4, but not related to thyroiditis, related to pseudotumor. Okay?
Okay.
Again, thyroiditis may cause thyroid orbitopathy due to this long-acting steroid stimulating antibody. This is a disease. And there are another disease called IgG4. It may cause autoimmune thyroiditis. It may cause orbital pseudotumor. Okay, my colleagues. Thank you so much, my colleagues. Let's meet
Okay. Thank
tomorrow.
you so much, Dr. Rani.